fixed. So presenting a 69 years old gentleman, Mr. J, had presented with chief complaints of unilateral headache, right-sided for the past 2 months. He also had right-sided ptosis followed by diminution of vision for the past 1.5 months. These are his presenting complaints. So he was apparently well before 2 months when he developed the headache. The headache was unilateral and it was right-sided and it is non-pulsatile and was not associated with nausea and vomiting. He does not have any associated photophobia, phonophobia, or preceding aura. Following the headache was gradually progressive and it is more increased with extraocular movements. Following headache, within 2 weeks, he gradually developed right-sided ptosis along with diminution of vision. And other than that, he also developed an acute onset weakness of left-sided upper and lower limb 1 day prior to presentation. Another positive history is he had significant unintentional loss of weight of around 8 kilograms in the past 2 months, and there was history of decreased appetite. Other than that, there was no history of fever, night sweats, or chills. There is no history suggestive of autoimmune etiology. There is no history of discharge from nose. There is no history of trauma in the recent past and did not underwent any recent neurosurgeries. Past history is a known case of diabetes for the past 10 years and is also a known hypertensive for 6 years on medications. There is a significant family or exposure history. So on examination, he was afebrile, was conscious to time and person, but not to place. Pallor was present, otherwise no icterus, cyanosis, clubbing, or lymphadenopathy. His vitals were stable. Respiratory rate is 19 per minute. Heart rate is 86 per minute and is regular. And blood pressures were 134/90. And central nervous system examination is higher motor functions as conscious to time person, but not to place. Cranial nerve examination showed the right second nerve. So the pupils were non-reactive to light and it is fixed. Third, fourth, and sixth nerve, extraocular movement, he had external ophthalmoplegia. The eyes were the movements were restricted in all directions in the right eye. Meanwhile, the left-sided, the pupils were reactive to light and movements in all directions were normal. Other cranial nerve examination is normal. He perceives equal sensation in both sides of the face and he is able to clench teeth. 7th nerve, 8th nerve, 10th nerve doesn't have any dysphagia, dysarthria. Other system examination is normal. Motor system examination wise, he had his bulk and tone is normal. And power, he had 0/5 in the right sided upper limb and it is 1/5 in the left sided lower limb. Otherwise, right-sided upper and lower limb power are normal. Sensory system examination, he is able to perceive pain and touch. Light touch, vibration, and joint position sensations were normal. Reflexes were biceps and triceps were exaggerated in the right side, and plantars were extensor in the right side. Sorry, left side. So there was no signs of cerebellar dysfunction. Gait could not be tested. There are no signs of meningeal signs, and spine and skull were normal, and other system examination is normal. So this gentleman, so he had presented with chief complaints of right-sided unilateral progressive headache, followed by he developed a right-sided ptosis along with blurring of vision. And with clinical examination revealed involvement of second, third, and fourth cranial nerves. He also had a human type of left-sided hemiparesis. So differentials, what could be the possible differentials or clinical localization? So in our case, so this person has gotten cranial neuropathies along with human involvement. So initial localization we consider as it is a right orbital apex or it is right cavernous sinus, or otherwise since there is human involvement along with cranial neuropathies, we thought if there is any lesion or infarcts involving the brainstem.
Sorry, I'll stop you there, Akash. How will you explain the hemiparesis with right orbital apex syndrome or a cavernous sinus syndrome?
Sir.
It's not a cranial neuropathy lesion. There is also definitely involvement of the pyramidal nerve, so it has to be in the brainstem, right? I understand.
I will explain, sir.
Okay.
So the right orbital apex syndrome, the differentials considered were either it is infectious etiology, neoplastic etiology, or inflammatory etiology. So infectious etiology considered there is chronic invasive fungal infections like aspergillosis or mucormycosis, or other infectious etiology like orbital cellulitis secondary to bacterial infections like Mycobacterium tuberculosis, Streptococcus, and Staphylococcus were considered. Neoplastic etiology, the patient may have had any underlying head and neck cancers or nasopharyngeal carcinoma, lymphoma like Burkitt's lymphoma, or nerve sheath tumors like schwannoma and neurofibroma. Inflammatory, either it could be sarcoidosis, Tolosa Hunt syndrome, IgG4 related disease, or endocrine causes like thyroid orbitopathy, or there is no history of trauma, or trauma history was also considered, or vascular etiology like cavernous sinus thrombosis, fistula, or aneurysm were considered. So on investigations, so is hemoglobin was normal 15.2, WBC is 11,300 with with neutrophils of 73, lymphocytes of 20, platelet count was normal. LFT, it showed an elevated alkaline phosphatase and had no coagulopathies. Renal function test was also normal. Urine routine showed glucosuria, other than that it was normal. He had no dyselectrocytemia, and blood-borne virus screen was negative. Also sputum expert and MGIT was also sent, which was negative, and chest X-ray did not show any infiltrates. So because we did an imaging of the brain, initially it showed an ill-defined lobulated mass in the right orbital apex and adjacent bony erosions with loco-regional spread. She also had an acute onset left-sided hemiparesis. MRI brain showed an acute infarct in the right posterior and internal watershed territories and multiple scattered foci in the right cerebral parenchyma. With an echo did not show any vegetations. Carotid Doppler showed only minimal intimal thickening in bilateral common carotid artery. And HbA1c was 6.9. So we also underwent, we also did the CSF. So CSF cell count was had normal protein and glucose level. Cytopsin study show no atypical cells, and the fungal cultures, bacterial cultures, and Indian ink was negative. So because of this, he underwent a endoscopic transnasal debridement. So following which the culture from that specimen showed grew septate hyphae, which is Aspergillus fumigatus. The biopsy is also suggestive of he had an acute on chronic sinusitis with luminal fungal infections. Morphology is compatible with Aspergillus. So the left-sided hemiparesis, the reason for it, why we considered is, considering the involvement of the territory, he had internal watershed territories. So the cause for acute infarct was considered secondary to hemodynamic stroke due to infiltration of the internal carotid artery by the invasive aspergillosis. So I want to mention a short term about invasive aspergillosis and right orbital apex syndrome. So orbital apex, it has superior orbital fissure, inferior orbital fissure, and optic canal. Superior orbital fissure, we have second nerve, third nerve, superior orbital fissure have third nerve, fourth nerve, sixth nerve, and V1 of the trigeminal nerve. And so presentation in orbital apex syndrome will be, these nerves will get involved. So that is oculomotor nerve, trochlear nerve, abducens nerve, and trigeminal nerve ophthalmic branch with optic nerve dysfunction. So this patient has got external ophthalmoplegia. They will have decreased or diminution of vision with ptosis, with dilated and fixed pupils. And there are other orbital apex disorders, and which are superior orbital fissure syndrome and cavernous sinus syndrome. So what is the difference between superior orbital apex syndrome, superior orbital fissure syndrome, and cavernous sinus syndrome? So in superior orbital fissure syndrome, there won't be second nerve involvement. So there won't be optic nerve dysfunction. Meanwhile, cavernous sinus syndrome, along with superior orbital fissure syndrome, you see there is also V2, that is maxillary branch of the trigeminal nerve will also get involved. So this is the additional thing which we can see in cavernous sinus syndrome. Usually cavernous sinus syndrome is bilateral. And what is aspergillosis? So it's a collective term caused by disease entitis of aspergillus. So it is a hyaline. It is a non-pigmented septate branching mold. It spreads via conidia. So there are many types: Aspergillus fumigatus, flavus, niger, teres, and nedulans. One of the most common organism to cause invasive aspergillosis, Aspergillus fumigatus. So considering its epidemiology, the invasive aspergillosis, it is incidence is high now recently. The global burden is around 850,000, and the mortality rate without treatment is 100%. So it has a worldwide distribution. Considering India, according to 2022, the annual incidence of invasive aspergillosis in India is estimated to be 2,50,900 cases. And most of the people, they had a chronic obstructive pulmonary disease. And risk factors, most commonly involved risk factors is the patient have got underlying lung disease, if they are using any glucocorticoids, if they have profound neutropenia or uncontrolled diabetes, neutrophilic or any phagocytic dysfunction in CGD and HIV. Now patients, unless he is a known diabetic, other than that, he does not have any underlying lung disease or other known risk factors. So either it can present as an acute invasive or chronic pulmonary aspergillosis, or either the presentation can be allergic to. So allergic bronchopulmonary aspergillosis, it usually complicates asthma and cystic fibrosis. So cystic fibrosis, invasive aspergillosis, the most common organ involved is pulmonary. Either it can, from lung, it can disseminate into other organs, causing disseminated aspergillosis. Can even cause culture negative endocarditis. From sinus, it can invade the brain to cause invasive sinusitis or cerebral aspergillosis. And other presentation could be orbital apex syndrome. So how can we diagnose? The most common, there are culture, or you can go by histopathology. Histopathology will show infarction of the affected tissue along with fungal hyphae, or there can be acute necrosis with fewer hyphae. Otherwise, PCR and antigen detection tests were also available. So considering diagnosis, according to histology, other fungi can also mimic aspergillus. Hence, a positive culture will also support the diagnosis, but only 10 to 30% of people with invasive aspergillosis have positive culture. So hence, to make a definitive confirmation, so the patient should have a positive culture of a sample taken from an ordinarily sterile site, or the positive results of both histological testing and culture of a sample taken from an affected organ. So in our patient, he had both histologically proven and culture positive aspergillus fumigatus from the specimen taken endonasally. So the treatment, the timely diagnosis and prompt initiation of antifungals has to be done to avoid fatal outcome. So most important, if it is surgically resection is possible, you have to do the surgical resection. And the first line drugs available is azoles. So initially preferred is oriconazole. It is given for 6 mg per kg on day 1. So it's 400 followed by 200. Alternatives, it is isoconazole or posuconazole. If there is a resistance to azoles, the second line drug we can consider is micafungin and amphotericin can also be given. So while giving azole therapy, we should also check for hepatotoxicity, any cardiac arrhythmias, and 30% of people even can develop a transient visual or auditory hallucinations. In our patient, we treated with oriconazole, and he also underwent a surgical debridement, and he's currently under follow-up with us. Thank you.
Questions and comments?
So I actually want to bring you back to the original point which Dr. Amit made. The localization is wrong. When you asked, Amit asked you a question, what about your localization? Your localization should be first from the clinical features we have. The clinical features are cranial nerves, and then on the other side is your upper motor neuron. You had a weakness. So both of them you cannot localize into the orbital apex even based on the presentation you have made later. So either you have to say there are two different in areas which are involved in the brain. That is where your localization is. You cannot make a diagnosis of orbital apex syndrome or a cavernous sinus thrombosis based on the presentation you have made. You have to say plus a stroke or plus or another localization to another area. So that is the issue I want to highlight. So because when people learn from me, they will think that is a diagnosis. No, you have clearly said. And also again, you mixed up superior orbital apex syndrome and orbital apex syndrome because you presented orbital apex and did not put second nerve. Then you went back and said superior orbital apex does not have second nerve. So when you make a presentation to a wider audience, which is also learning, you have to be very meticulous with the presentation. And the other issue is, I wanted to say is, when you did the epidemiology, you're talking about the epidemiology of pulmonary aspergillosis, not CNS aspergillosis. So you're mixing up stuff. So it's like very difficult for you or a young learner to separate and learn. So you should be very clear and careful in your scientific presentations.
Any other questions?
There is no evidence of second-nerve involvement from your clinical examination because you're seeing the left side of your reactions are completely normal, which will not be the case if you have a second nerve involvement on the right side. So you may not have an orbital apex syndrome at all based on the presentation. It may just be a superior orbital tissue. You said it's a cavernous sinus thrombosis in your case, but again, P1 is not involved. So yeah, your localization was not correct.
So you didn't present the trigeminal. Actually, you didn't present trigeminal involvement at all.
Are you sure that there was no trigeminal involvement?
So actually, yes, consciousness been quite. So I was not able to clearly make sense. But
sure. You can have partial deficits. It can be there. I mean, just because you don't have trigeminal, will not rule out cavernous sinus. But second nerve involvement is something that you have to clarify. Did you do some visually evoked potential or anything? No. To clarify if there is a second element.
Certainly.
No, if there are no other comments, thank you, Akash. I would suggest that the discussion be made very focused. So if you want to discuss invasive aspergillosis, then discuss only invasive aspergillosis. If you want to discuss CNS aspergillosis, then only CNS aspergillosis. If you want to discuss localization of cranial nerves, then only that, because otherwise it will become too lengthy and too difficult to concentrate. Thank you. Did this patient have any risk factors for invasive aspergillosis?
He's a construction worker, sir. He's a known diabetic.
He's a diabetic.
Yeah.
Uncontrolled.
HbA1c 6.19, sir, but there's
Not too
past
bad.
history of insulin usage is there.
Thank you.
How common is it? I mean, competent individuals getting serious aspergillosis is common in this sense, because of the chest infection. Are there other case reports or is it like?
There are multiple case reports. Currently, yes, immunocompetent. Most of the people have underlying lung disease and diabetes.
So that is a problem. Akash, underlying lung disease causing aspergillosis is invasive pulmonary aspergillosis.
Orbital apex syndrome.
But the primary area where the aspergillus enters will be the lung, right? So it will not be an isolated CNS aspergillosis. I mean, I do not know unless you're saying that the lung.
I have seen cases in this that used to do with IOL in the scans. So during that time, we used to get implanted and go and talk with the infects actually. What you're saying about the lung is what Amit is saying, what I'm trying to say. In epidemiology, you're talking about is pulmonary aspergillosis. It is not CNS aspergillosis.
Or it may be multifocal. But I mean, but the lung involvement has to be there. Here, I don't think there was any lung involvement.
No, sir. No lung.
Thank you, Akash.